All right, which of the following antiepileptics can cause pancreatitis and hepatotoxicity? You see the answers, okay? So you have clobazam, benztropine, valproic acid, or lorazepam. What do we think? All right, yes, valproic acid is known to do that, right? So hepatotoxicity for sure. What else is notable about valproic acid? Neural 2 defects in pregnant women, right? You can see the hyperammonemia that can develop there. But pancreatitis is kind of a unique one. Not a lot of drug-induced causes of pancreatitis. So that's a pretty interesting thing there. Clobazam is what kind of drug? It's a benzodiazepine. What else is a benzo on that list? Lorazepam, very good. And then benztropine is what kind of drug? What do we use it for? What disease state? That's an anticholinergic. Remember, we used it in Parkinson's disease for arresting tremor. Okay? Remember, be able to link those drug classes back to where we're using them at, right? All right, which of the following have the potential to cause physical dependence and addiction? Be codeine and Tylenol, morphine, tramadol, or methadone. Should be fresh in your mind. So we just reviewed it. All of them are correct. Remember, I can give you trick questions here, just not on other stuff. So remember, anything that acts at the opioid receptors can cause physical dependence, and the risk for addiction. Remember, physical dependence can happen 100% of the time. Patients are on it for a long enough period of time. It's the addiction aspect that is more, nebulous, right? Depends if they have the right kind of risk factors for it. But yeah, any of these can do it, right? And tramadol is kind of a weak opioid agonist. Any of the other ones are full agonists. They can definitely do it, right? Okay. A person with acute pain after a dental procedure would most benefit from which medication? Be fentanyl patch, oxycodone extended release, heroin IV, or hydrocodone acetaminophen.
That last question should be on the test.
I will not put that on the test. I don't put silly questions on my test.
Serious here. Someone's nope.
No heroin, that's good. That's probably the first that no one decided to give up their points. So why would a fentanyl patch not be great?
Slow.
Remember, it's slow in onset, right? It takes 12, 24 hours before it really starts to permeate through the skin to get to the systemic circulation. So that's not going to be good. Better for chronic pain issues. How about the extended release OxyContin?
For chronic pain.
Yeah, it's for chronic pain. You don't need that 24, the 12-hour sort of duration of action with that one. So that's not really going to be appropriate there. But certainly, a prescription for hydrocodone and acetaminophen makes sense, right? So how long could you write that for in terms of duration?
3 days up to 7 in community exemption.
So you could do 3 days at a baseline, and then you could write what on the script to get a longer period. You have acute pain exemption, right? And then you'll document your chart why you thought that was necessary, and then you get a total of how many days? 7 you could write for, right? So depending on how painful you thought it was, how much they need, you could write for more, right? Okay. All right, in the lead.
Mr. Doctor Wood, that's awesome.
Which agent can be used as a prokinetic in a patient with gastroparesis? Use esomeprazole, sodium bicarb, cannabis, sativa, or metoclopramide.
Got this, baby. No pressure. You didn't answer, so I'm not looking at it. That's pretty good.
How'd you know she didn't answer?
She still had the choices.
Why are you looking?
Need some help, apparently. I'm a little slow. I need some cooking.
Okay, so what is esomeprazole going to be used for?
GERD.
GERD, because it's what kind of drug? PPI, right? Decreasing acid production. How about sodium bicarb? antacid, right? So it's going to be neutralizing acid. Okay. Cannabis. It'll help with appetite stimulation. It'll help with nausea, vomiting. Not necessarily going to be a prokinetic, right? But certainly Reglan is going to be the one on there, right? What other drug could I use as an alternative? Erythromycin, yeah, absolutely. Remember, erythromycin acts on those motilin receptors. So if they have any kind of gastroparesis, especially like with diabetics, you think about that. Those two drugs are going to be good ones to go with. Okay. Which med is indicated for a DVT in the post-operative period after a hip replacement? I'm going to give enoxaparin sub-Q, alteplase, aspirin, or warfarin. Definitely know we just covered this.
Got this with you.
Very good. Yes, enoxaparin would be a good one to go with, right? Because why would that be the most appropriate in this setting? Onset of action is immediate, right? It's going to immediately start to interact with antithrombin 3 to inactivate 2 and 10, 10 being more predominant with that one in particular, right? How to monitor for its effects? Anti-10A, right? And you don't have to do it for, majority of patients don't actually need any monitoring, right? But if you needed to, pediatrics, people with extremes of weight, you could certainly do it for them, right? Alteplase would be used when? They're having a massive PE, like they're getting kind of like shocky from it, they're hypotensive, syncopal. That's when you give them the dose of alteplase potentially to try to lyse that clot and get rid of it. What's the big risk with using TPA though? Huge bleeding risk, right? Bleeding anywhere can occur, right? So that's why sometimes we'll actually do, if it's possible, they'll do like intravenous actual administration. So they'll actually use, go to the cath lab and actually have a line put right where they can just administer it right into the clot itself. So occasionally, that can help to mitigate some of that. Warfarin wouldn't be appropriate, because why? Yeah, it takes a couple of days for it to really kick in, so it would not be appropriate in that case. And if anything, it could make it worse. Because remember, you lose that protein CNS, and that actually has some anticoagulant effects, right? Okay. What else could I have used for that one? Heparin could have been good. What else? Rivaroxaban, apixaban would have been appropriate there as well, right? Okay. Which of the following meds would be best suited for migraine prophylaxis? Would I use DHE, sumatriptan, propranolol, or oxycodone and acetaminophen? So we only have like 40 more questions to go. I wish you went for lunch. Very good. Propranolol is a good preventative medication for migraines. DHE would be good for what? That's part of that abortive therapy, so that's good for acute treatment of a migraine. Similarly, what else could be used for that? Sumatriptan would be another one, right? So how did those work to treat migraines? They constrict the vessels, right? How do they do that? Yes, 5-HT, 1D, and 1B agonists, so serotonin receptor agonists, 1D and 1B specifically, right? Who would DHE not be a good candidate for? Who would not be a good candidate for DHE, I should say? Yeah, history of like, stroke or MI, who else? Pregnancy would be not a good candidate, right? It's a category X drug, right? What's the risk with using propranolol for migraine prophylaxis, though? Remember, these are going to induce migraine in and of themselves, right? So you got to start low dose and titrate them up, right? Because again, even propranolol could actually dilate those vessels if you give them too big of a dose initially. What could be an alternative? Say they have asthma and they can't take propranolol, what could they use instead? They're not a good candidate for a beta blocker in general. What else? Calcium channel blocker could also be used, right? Say they can't receive any cardiovascular meds, they're already hypotensive, they're bradycardic. Triptan is only good for acute treatment. There are things like topiramate, right? Some of the other anti-epileptics can be used, but topiramate is starting to get a lot more use there. I've seen valproic acid used before for some more treatment-resistant cases, but those can all be beneficial, right? Okay. And opioids really should be last line. If everything else has failed, that's when you can try going with that. Which medication route is least preferred during an acute seizure? The least preferred would be rectal, intravascular, intramuscular, oral. Correct. The oral route is least preferred. Why? They're an aspiration risk, right? You might try to give them something and they might lose the tip of your finger or something, right? Might bite down on you. Yeah, aspiration risk is the big thing there, right? So you can sort of still get things rectally, right? What is, and that's for a long time is what we did most commonly. What is starting to become more popular now, though? Intranasal, right? So we actually have intranasal. Midazolam is the most common we can use in that case there. Sort of IV or IM, totally fine in those cases, right? All right. Which medication would be contraindicated from who would be contraindicated from receiving frovatriptan? This one I already gave away. So psoriasis, history of ischemic stroke, hypertension, HCTZ, or ergot use last week. Yes. So remember, because it's a vasoconstrictor, if they're at risk for stroke, that could induce that potentially. So that would not be a good candidate for that. In terms of ergot use, what's the time frame we're thinking of? Like 24 hours or so, right? Maybe 24, 48 hours, depending. So that would be one I'd be very cautious about using if it was much closer. If it was last week, I don't really care so much because that drug is out of the system at that point, right? How about the hypertension? You know, it's well controlled. What if it was non-controlled? What if their blood pressure is like, 190 over 110? Not great either, because again, they're going to be at risk for cerebrovascular issues there. So you would want to avoid that. And psoriasis doesn't really matter. Okay. All right. What can be given to patients when receiving infliximab to prevent infusion reactions? Give them Humira, epinephrine, diphenhydramine, or methotrexate. An infusion-related reaction. Very good. Yes. So when I say infusion reaction, what do I mean? Flushing, itching. What else? Maybe a little hypotensive. What else? Maybe some anxiety. About temperature. You can see fever, myalgias, right? So those are infusion-related reactions you can find there. Obviously, Benadryl would be used if. When would I use epinephrine though? Yeah, they're having an actual anaphylactic shock or anaphylactic situation. So again, if they were having any trouble breathing, if they're hypotension, if it's just more than a little drop in blood pressure, those would be things that would be triggering me to say, okay, I probably need to give epinephrine at that point, right? Humira, would that ever be a good combo with infliximab? Why not? They do the same thing, right? They're both working on tumor necrosis factor alpha. Would not make sense. When would I use methotrexate though? Right, they can be used together chronically because if you think about it, remember that not only can they have some synergism when working together to help them work better for rheumatoid arthritis, but also, if you recall, methotrexate can be used to prevent our own body from generating antibodies to make the infliximab less effective. So you can actually extend out how long the infliximab can be good for those patients by giving methotrexate along with it, right? So for both therapeutic effect and to help out the Remicade in the long run, okay? What is Otis Campbell? Anyone remember what that mnemonic was? They're medications that cause seizures, right? And the list is very long. Anyone want to go through it? No, I didn't think so. I'll do it anyway. Oh, no, I was about to say, don't get out of the game, but I guess I could have kicked him out. Which of the following antiepileptics work by facilitating increased GABA activity? Would it be lamotrigine, carbamazepine, phenytoin, or phenobarbital? Very good. Yes, phenobarb is going to be helping to actually open up that GABA channel, allow more chloride to flow in, hyperpolarize the cells, right? How do things like phenytoin and carbamazepine work? Good sodium channel blockers. How about lamotrigine? It'll also do some sodium channel blockade. What else does it do? Probably some glutamate effects too, right? So probably helping to inhibit some glutamate. So it has some kind of mixed actions there. What's kind of the claim to fame for lamotrigine? Why would you go that one over, say, phenobarb? Much less sedating, yeah. So again, if I have like an adult patient who like needed to go to work, like lamotrigine might be a better option for them, right? What might be a bad problem with starting someone on lamotrigine? Stephen Johnson, but certainly rash can be a big one. That should definitely prompt discontinuation of use for those patients, right? Can you still get Stephen Johnson's with like phenytoin and carbamazepine? Yeah, absolutely, right? So you do have to be cautious. Just more common with lamotrigine, okay? Biggest risk of phenobarb? Maybe sedation, some hypotension you can see with that. Which one of these are a controlled substance? Phenobarb, yeah, the barbiturates, and what else did we mention was also a controlled substance as a class? The benzos are the most common one, right? There's a couple other ones, a couple newer ones I didn't mention that are also, but those are the big things to think about. Phenobarb, or barbiturates in general, and then also the benzos are going to be your most common ones. We actually had a patient who was on pentobarb the other day. They were having all kinds of intracranial pressure issues. They had a VP shunt in. They were on hypertonic saline. They were on pentobarb drip to try to keep all their pressure, intracranial pressure under control. And they had to go down for an MRI, right? And so one thing about pentobarb is it's very expensive. It's like $1,000 a vial, right? So these drips only come like in a 20 ml syringe. And so the nurse had to take the patient down to MRI. But what do you think could be an issue if you have like a patient who's on a medication pump and they're going to MRI? There's metal in the pump, or at least on the stand, and that can turn into a javelin as it goes right towards the MRI machine, right? Be very careful with those magnets, they're quite powerful. So anyway, so they end up having to hook up like 4 extension lines of tubing from outside of the room just to keep it on the patient, to keep everything going. And so all of that tubing, guess what? That's a lot of volume there. So they ended up losing like 18 mLs of volume for about 20 ml drip. So when they came back to the PICU, guess what? Nurse calls us up saying, hey, I need a pentobarb drip stat. Like, oh great, because now we got to like reprioritize everything and move everything around and make sure we get this drip stat, because you don't want the patient to run out, because then ICP starts to go up. Not great, right? So anyway, so we made sure we talked to the providers. Okay, are you sure that you're going to keep this going, right? You want to continue this drug? It's like $1,000 a vial. You sure you still need it? She's like, absolutely, I still need it. Great. Oh, we made it up. Got over to them lickety split. 5 minutes later, what do I get in my queue? Discontinue order for the pentobarb drip. All right, there's $1,000 down the drain, but. Anyway, yeah, so definitely a controlled substance. Some of them can be more expensive than others, so that's the takeaway. Which agent would not be used in the treatment of H. pylori? It would be omeprazole, amoxicillin, alginic acid, or bismuth, subsalicylate. You guys are so quiet. Almost hear your brains working. All right, so remember, so when you're thinking about like a 3-drug regimen for H. pylori, what are we thinking of? So you want a PPI, right, typically, so like omeprazole, lansoprazole, rabeprazole, any of those are fine, right? And then what else? You can use an immunopenicillin, like amoxicillin plus, like clarithromycin is usually kind of your go-to for those. But what else could I use? Say they had a penicillin allergy, they couldn't receive it. Metronidazole is another option. Tetracycline can be used in place like clarithromycin potentially, right? So those are your 3 drugs there. And then if I wanted to use a 4-drug regimen, what do I add on? That's where the bismuth comes into play, right? So it has some extra inhibition effects on H. pylori. The alginic acid, you can find that in some over-the-counter products. Again, it forms that kind of that thick paste when it combines with bicarb in the stomach acid. It's not all that effective, but you may see it used occasionally for some over-the-counter stuff. Okay. Why is that name? It's got some maturing to do. Just kidding. Which of the following is true regarding medical marijuana? The weight loss is a common side effect. Oral administration has the fastest onset. May only be prescribed for indications supported by randomized controlled trials, or short-term memory loss is a potential side effect. Absolutely, yes. So, what was I saying? No. Short-term memory loss, yes, for sure. So weight loss would not be a common side effect. Typically, you see what? Weight gain, because it's an appetite stimulant, right? Fastest onset would be inhaled route, right? So it's going to be much faster than the oral onset, as we mentioned. And again, what can you use it for?
Whatever you want.
If you can justify it, and again, I would consider make sure you're documenting whenever you're writing down your charts, then you can go ahead and go for it. Again, though, it's only certain providers going to be doing this. You have to go through certain. Again, can PAs prescribe medical marijuana in Florida? Cannot. Actually, has to be a physician who has undergone special training. However, you may see some people are helping out with the process, right? So maybe they might do like medical clearance and things like that to kind of help the physician along. So it just depends on the situation. But you yourselves will not be able to prescribe this, at least in the current legal climate. Who knows in the future, though? Okay. Mesalamine enemas, or OASA, would be most likely benefit which patient? Constipated patient, GERD patients, ulcerative colitis patients, or Crohn's disease patients? Remember, it might trick you. It might put more than one right answer, you know? You never know.
But most likely, it's a tier system.
Interesting. Oh, I'm starting to see through my ruse, my facade, if you will. So, mesalamine enemas is what kind of drug? The aminosalicylic acid, right? It's 5-ASA. Okay. So, what is that used for?
IBD.
Inflammatory bowel disease, right? But the enema specifically is only good for what? Ulcerative colitis, and more specifically, just that left-sided colitis, right? If it's more diffuse than that, and taking up the whole colon, then this is not going to be effective, right? Why is that? Enemas can only go so far, right? It's not going to be able to get back past the left side there. So in that case, there, it's only good for UC. If you had an oral option, though, if, let's say an oral ASA product, then certainly Crohn's disease could also be correct in that case there, right? You saw enema, though, and you probably thought constipation, though, right? But what kind of drugs do we use as an enema? We use hyperosmotic agents like your sodium phosphate. We can use things like, sometimes we'll use like a bisacodyl enema as a stimulant. There's a couple different options there, but usually like a Fleet's enema or sodium phosphate enema is kind of the most common. Sometimes we'll do like mineral oil enemas. It just depends on the case there. People have used like soap suds before. That can be effective. Lots of different options. Okay. Which of the following meds carries the biggest risk for rash and Stevens-Johnson, which I probably gave away already? Would be Keppra, phenytoin, fluoxetine, or trazodone? Let me think here. I forgot to change these two answers. Last year we had behavioral in the same section, so that's why I have two behavioral meds on there. So that was an oversight on my part. So you probably already guessed two of them were not candidates. Right, so remember phenytoin, carbamazepine, lamotrigine tend to be kind of the biggest risk. Oxcarbazepine could also do that. What particular kind of unique risk would I see with like carbamazepine and oxcarbazepine? Hyponatremia, why? Because it causes SIDH, very good. What do I worry about with Keppra? Not much, but the unique thing is aggression you see with kids, right? Okay, very good. These two we'll cover in the behavioral health section next time. Okay, which medication for RA works by inhibiting Janus kinase proteins? Be it etanercept, methotrexate, tofacitinib, or tocilizumab?
Nice pronunciation.
Thank you.
That's very cool.
And practice. How do you know I'm saying them correctly, though? I am likely the only person you've ever heard say it. So you have no idea. I could be infecting you with incorrect pronunciations.
What if I'm an excellent pronunciation?
I'd be amazed. Can I tell you a funny story real quick, though? So my mother-in-law, I found out, used to say certain idioms incorrectly, and because it was just kind of like a funny in-joke she had, but then my wife and her sister had no idea. So my wife has been using the incorrect idioms for like her entire life until I found out about them. So the first time I found this out was when she said that she was so hungry she could eat the side of a barn. And I said, what? And she goes, I'm so hungry I could eat the side of a barn. And I said, no, you mean you're so hungry you could eat a horse? She goes, why would I eat a horse? I was like, because that's the saying. She's like, well, why would you eat a horse? I go, why would you eat the side of a barn? Really kind of shocked her world there for a little bit. I've corrected some of those now. She also used to say down the hatchet. Said down the hatch. Which I also found pretty funny. And her mom laughed so hard when she found out. She's like, oh, I thought we were just joking. I didn't know you took that seriously. Anyway. Which medication blocks sodium channels to prevent neuronal transmission of pain signals? Buprenorphine, capsaicin, lidocaine, or naloxone?
Brandon's nod of approval.
Yes, all right, so buprenorphine is what kind of drug? Buprenorphine is a partial agonist at what? Mu opioid receptor, right? So it's a partial agonist mu opioid receptor, really only used for opioid addiction, right? Capsaicin does what? Depletes substance P, good, so help to decrease, kind of sensitization of those nociceptive fibers, right? And then naloxone, opioid receptor antagonist, right? It's a rescue medication there. So lidocaine, like all the other local anesthetics, will block those sodium channels, and that's what prevents that propagation. That's why we get that numbing effect, because again, the signal is never making it up to your brain. We'll talk more about those when we get to the surgery section later on in the class. Right. Which of the following NSAIDs is preferred in a patient with a history of GI ulcer? Use meloxicam, ketorolac, naproxen, or ibuprofen. So most of you are probably looking for which answer? Celecoxib or Celebrex, right? Well, I didn't do that. I want to challenge that gray matter.
Didn't do that.
Very good, yes. So remember, your Toradols, your Motrins, your Aleves, those are all going to be non-selective inhibitors. Really the biggest ones are going to be celecoxib, which is going to be the most COX-2 selective out of the bunch we have. Meloxicam is moderately so. Totolac might be another one you see occasionally. That one will also be somewhat selective for that one, but those are the big ones. Very good. Which of the following is not a common effect seen with hydromorphone or Dilaudid overdose? Not a common effect. We see hypertension, meiosis, lethargy, or respiratory depression. Right, hypertension you would not expect to see in those cases. Could they develop hypertension in any other setting with an opioid? Maybe with withdrawal, right? You may see some bumps in their pressure just because they're so sort of kind of hypersympathetic sort of state there, but nothing too severe in those cases. Certainly you see meiosis in many situations, but not always. So some people I've seen will kind of discount an opioid overdose. They say, well, they're not meiotic. don't have to pinpoint pupils, they can't be that. And I'm like, no, it doesn't always happen, right? So, but that's something you commonly think about. And then certainly lethargy and respiratory depression for sure, right? So those are big things you see with that. All right. Prior to starting treatment with alemtuzumab for multiple sclerosis, patients should be tested for influenza A and B, tuberculosis, strep pneumo, or Lyme disease. We used to check for lemon disease, but that went by the wayside. Very good. Yes, you should check for TB in those cases there, right? Really only check for flu if they were actually having like symptoms that were consistent with that. But why do we check for TB before alemtuzumab? Because if they have a latent infection, you're going to suppress that immune system, and that can then lead to activation. Right. Very good. I forgot to ask a question. So that previous one, we were looking at the different agents for RA. I was asking about the Janus kinase inhibitor. We saw like tocilizumab. How did that one work? That Actemra. And that was an antibody against IL-6. Okay. How about etanercept? That was a TNF alpha. Remember, so we talked about 3 main ones that affect TNF alpha. And I don't remember what the other option was there. How about methotrexate? What does that one do? Folic acid antagonist. Yes, very good. All right. Colchicine or Colchris would be best suited for patients with, and I included an autumn crocus, osteoarthritis, gouty arthritis, rheumatoid arthritis, or osteoporosis. Very good. Yes, we use that one for gout. What can I use as an alternative to colchicine potentially, or an acute gouty attack? NSAIDs, probably most commonly. What else? Steroids, corticosteroids you could use potentially. Yeah. Yeah, it's really only good use for colchicine for the most part. How does it work? It inhibits those mitotic spindles, so it kind of prevents a lot of PMNs from actually getting to the site of inflammation. You kind of have to deal with it from that standpoint. What's the biggest side effect you're going to see with colchicine? Yeah, nausea, vomiting, diarrhea for sure, right? Because it's going to be very harsh on the stomach because it also affects the replication of your rapidly dividing cells, right? So GI tract gets affected for sure. Okay. Which agent would allow for the fastest healing of a gastric ulcer? Sucralfate, lansoprazole, cimetidine, or magnesium hydroxide?
That's so sad. My beautiful timing. Maybe I would have been able to take that over.
Can we look up the mag citrate reviews? Should. It's still very funny. Yeah, those are pretty good too. I like the sugar-free Haribo gummy bears. Classic. We did that one winter, when Christmas break.
You did them or read them?
I consumed some and not great.
He's here to tell the tale.
It's not great. Anyway, so yeah, which one's going to be best for helping to heal a gastric ulcer? So you want the thing that's going to have the most inhibition of that stomach acid production. So your PPIs are going to be it, right? What would be kind of next down on the list here? Right, H2 blockers like cimetidine, right? But we never use cimetidine because CYP 3/4 inhibition. Very good. What could I use instead? Ranitidine, famotidine, nystatin was the other one, right? So this is 4. Carafate can be like a useful add-on, but not going to be the thing that really kind of to do that. And then issue with magnesium hydroxide. It's going to be very limited. Like antacids are only going to be working as long as they have that buffering capacity. Once they've been neutralized, that's it, right? So, and then magnesium hydroxide more likely to cause constipation or diarrhea. Diarrhea, right? It's hyperosmotic. Okay. A patient is taking hydrocodone and acetaminophen 5-3-25, 6 tabs daily. How many 500 milligram Tylenol tabs can they take in a day? You seen that meme of like the middle-aged lady with all like the math stuff around their head? Starting to see some of those pop up.
I should have done the calculation before guessing.
Oh boy.
I had to think, okay, I'm in a spot where I have to take risks now, though. At the same, I'm also a strategy guy.
It's the best laid plans of mice and cams.
What?
The best laid plans of mice and cams. Their strategy. Yeah, mice and men.
That's pretty much me. Dang it. So I know the answer now. This is a tough one. This is one that defined you.
Interesting. Wow, but the majority got it correct, right? So what am I looking for here? What's the max the patient can take? 4 grams in a day. Okay, so how would I figure this out? 325 milligrams times 6, so they're taking 6 in a day. So I think you get like 1950 or something, right? And then, so then how many 500 milligram tabs can I take on top of that? Maximum of 2 grams, right? Additional, so divide by 500, and boom, you get 4 tablets. Very good. Now you could say, well, just don't take anything outside of the hydrocodone. That'd be the safest thing to tell them. But some patients will still want to self-medicate, and you can say, okay, well, you can take them if you. This is how many Type you take. This is the maximum of Tylenol you can take in addition. Okay. All right. Assuming they have a healthy liver, right? Because then it goes down if they do not. Last question: a patient with no insurance and occasional GERD symptoms with most benefit from which agent? They're very cost conscious. So would I use misoprostol or meprazole, polyethylene glycol, or calcium carbonate?
What?
Very good. Calcium carbonate. Why is that? Cheap, right? And it's just occasional GERD symptoms. It's not something that's happening long term, right, or more chronically. What's polyethylene glycol for? Constipation, right? Good. Rabeprazole is what kind of drug? PPI, typically prescription only, more expensive, right? And then misoprostol is used for what? Yeah, to prevent NSAID-induced ulcers, right? Very good. Okay, let's see who the winner is. Have Otis Campbell. Who's that? Who's Otis? Nobody? Emily. Very good. Who's that? Who's Unicorn? Very nice, very nice. And then who's Eyeballs? Oh, very good. You guys are kind of probably in cahoots, if I had to guess. Quite literally, right? Whoa. Okay. So your free answer for the test is? Any guesses? Interestingly enough, it's actually Archduke Franz Ferdinand. Any other questions I'll let you guys go? Nothing else. I'll see you next time.